Thank you so much, George. It's really an honor for me to be here. I'm very happy. The connection between Greece and Italy and the other countries is getting better and better with this project, which is called eCRIM. I think that we will do a lot of interesting research together. Well, let me start from this consideration. Emergency medicine is the oldest practice, but the newest discipline in medicine. I know yesterday you had a lecture, an interesting lecture, that has been shown that the same Hippocrates practiced emergency medicine. And this is interesting and in some way expected. But emergency medicine is also very new as discipline. And this is some way contradictory. In Italy, emergency medicine specialist has less than 25 years, which is a baby in respect to the other specialty. And in Greece, you still don't have a real emergency medicine specialty in the country. So why is this possible? I think that one of the key reasons why emergency medicine is one of the oldest practice in some way connected to time. When you face an urgent issue, an emergency, you have no time to reason, to wait and see, to expect. You have to act. So even the very first people who were involved in medicine, like Hippocrates, they had to practice emergency medicine, because when you have an emergency, you have to act. Well, but I think that even the reason why emergency medicine is very new as discipline is also connected with time. To be a discipline, you need to systematize your practice. You need to collect data, to collect evidence, to prove the efficacy or non-efficacy of your interventions. So it requires research, which requires, of course, know-how, specific competences, require resources, but require times. Require time because you have to collect data, to analyze data, and you have no time. I don't know exactly what is the situation here in Greece, but I can tell you that in Italy and in the other countries, I know emergency physicians do not have time. We computed that in Lombardy, which is the richest region in Italy, each doctor has, on average, 33 minutes per patient in the morning and afternoon shifts. And during those 33 minutes, they had to visit the patient, ask for new diagnostic tests, review the results, asking eventually new tests, and speak to the patients, to the relatives, register all of this on electronic health record, and so on and so on. Find a bed if you want to hospitalize the patient, or contact the general practitioner or primary care services, all in 33 minutes. And if you want to do research, it requires time. We calculated that to adhere to a project in emergency medicine, some of the projects we organize in Italy, it took about between 15 to 30 minutes per patient, which means that you have to double the physicians in the emergency department to participate to research project. So research is very difficult in emergency medicine. And this is the reason why the scientific status of emergency medicine tends to be low. And it's considered low by the other colleagues, by policymakers. And this is a sort of vicious circle. Consider, to have an idea how policymaker evaluate, assess your quality, the quality of emergency medicine. What are the indicators they use? But you know that traditionally, the indicators that we use to assess the quality of care are those three that were proposed by Donabedian several years ago. You have to consider structure, process, and outcome of care to assess the quality. Well, I think that after so many years, these indicators should be increased. We have at least to consider 6 of them. For sure, structure. You have to assess what you have to perform healthcare. You have to study the integration with the outside world. That for you means the primary care services and hospitals. And the process should be divided, should be split in organizational and clinical process, because this is very important for you. Then you have to assess the appropriateness in resource use. If you consider a hospital as a healthcare resource, you have the responsibility to decide patients who deserve that kind of resources. So you should be evaluated, assessed even on the appropriateness of the use of this resource, and of course the outcome. But let's look at what kind of indicators they use to assess your quality of care. But do that with the perspective of the Cheshire cat. When Alice in the Wonderland asked him, "Will you please indicate me the way to get out of here?" She's asking him to act as an indicator. And the Cheshire cat answered, "It largely depends on where you want to go." This is a key characteristic of every indicator. They depend largely on where you want to go. So let's look at what kind of indicators they use to assess you, to understand where they want to go with the emergency department. Well, of these indicators, the only ones that are used are organizational process indicators. I don't know if this is the same in Greece, but in Italy, emergency departments are assessed in terms of time to visit, time to needle. Time is something, a nightmare for you, but also length of stay, patient processed per doctor, admission rate, all organizational indicator. There is nothing about the clinical process of care, nothing about the appropriateness of use of resource, nothing about outcome. I don't know if they want to go there, but surreptitious or not, the adoption of just organizational indicators vehicle the idea, the message that emergency department is a place, how can I say, is a machine that has to produce quantity, not quality. Emergency department is the place where patients are processed and sorted, not a place of care. And this generates frustration, because this is what they expected you are doing. So I think that it is time to change. Otherwise, the scientific status of emergency department will never rise. But to do that, we need detailed, high quality, reliable data from emergency department. This is the only condition to perform research, and with this to increase the overall quality of the disciplines. George told us that I worked for almost 30 years with intensivists. I would like to show you what we did and we still are doing with intensive care units. This is one of our projects for quality of care assessment. Basically, we collect an enormous amount of data on patients at the arrival to the ICU. Their characteristics, their clinical demographic characteristics, to feed the mathematical model we perform that is able to predict the probability each patient has to die or to survive. This probability computed by the model is the average expected mortality, the mortality you expect on the average, on a supposed average ICU when treat the patients. So by applying this model to all the patients of each intensive care unit, you can compute the expected mortality of each ICU. That expected mortality is what you expect if that ICU would perform as the average of the ICUs that participate to the project. Consider that in our network, ICU network, now we have about 200 ICUs participating, and in many different countries, including Greece. So for each ICU, we have the expected mortality, which is the average performance. And so we can compare the expected mortality in each ICU with what we observed in the same ICU. This is, for example, a way to do that. This is the calibration belt, which is the representation with 95% confidence interval of the relationship between expected mortality here in the x-axis to the observed mortality in the y-axis. So this is the calibration belt of one of the Italian ICUs. And you can start assessing the quality of their job. Because if the calibration belt was on the bisector, it means that that ICU is performing like the average. The bisector is where the abscesses is equal to ordinates. So in this ICU, you can see that for this group of patients, those with lower severity, patient with low expected mortality, this ICU perform better than the average. Because if the patient has a 20% expected mortality on average, in that ICU, the mortality is 10%. The observed mortality is lower when the calibration is behind the bisector. But this ICU also performed worse than the average in very sick patients, those with a higher expected mortality, and because the calibration belt is above the bisector. So this ICU now knows that they perform better than expected in low severity patients, but worse than expected in higher, in very sick patients. They can do much more. This is an example. This is an ICU with probably some problem with low severity patient because the calibration belt is almost above the diagonal, but they can stratify this in different subgroup of patients. So they can stratify and perform the same analysis in emergency surgical patient, elective surgical patient, non-surgical patient. And you see that in emergency surgical patient, they are on average. Their belt is on the bisector. So what they observed in terms of mortality is exactly equal to the expected. The same in elective surgery, but not on non-surgical patients. So that overall situation was the results of different performance in different subgroups of patients. And they had a higher, much higher expected mortality in non-surgical patients, not very sick, with an expected mortality between 2 and 52%. Again, they can ask, but we perform so bad on all non-surgical patients. Again, they can stratify the analysis. Non-surgical patient entered with cardiovascular failure? No, they are on average. With metabolic failure? No, on average. Renal failure? On average. Respiratory failure? Yes. So they performed worse. They had higher mortality than expected, not in all non-surgical patients, in those non-surgical patients that entered the ICU with respiratory failure. All these patients, again, well, if they were intubated for airways maintenance, they were on average. So these are patients in coma. Patients with hypoxic respiratory failure, they are on average. With hypercapnic respiratory failure, they are absolutely out of the range. They had much more death than expected in COPD patients. And they review the way they ventilated these patients, and in 1 year, they decrease mortality of this patient, and they improve the overall quality of care indicator. Here is another example. This is Vlad. This is, it's long to explain, but easy to interpret. It's a sort of a stock chart of your ICU, of your unit. So if the Vlad goes up, it means that you are gaining something. You are gaining lives. If the Vlad goes down, it means that you are losing life. This is a very good ICU. At the end of the year, they had 20 less deaths than expected. But most happened in the first 3 months. They gained 15 out of 20 saved life. So they can reason what happened in those 3 months that we were so good in our performance and why we decreased the performance. This is another example. This is an ICU in 2008, which had a very bad blood. And at the end of the year, they had 12 more deaths than expected. This is based on a model with 100 variables. So it's very, very accurate model. We put together also the Vlad of the previous year, 2007, and these are in continuity. So you can put them one after the other, and it is absolutely clear that something happened on July 2007. We asked them, what happened in July 2007? Believe it or not, in July 2007, the chief surgeon changed. And these decreases are patients who died after elective surgery with a very low expected mortality. They fighted with the surgeon. They changed the overall organization, and after years, I have to admit, not in 1 year, but after some years, the situation changed. They avoided to do some intervention in that hospital because it was really risky. But without this analysis, they would never realize this. So our challenge is to substitute intensive care unit with emergency department and probability of die, for example, with probability of admission or discharge, which is the last decision you have to take on your patient. So imagine to have as a feedback a calibration belt, Vlad, and many other indicators. I have no time to present you on your performance in terms of probability of admitting or discharging a patient. And you, with be able to stratify this according, for example, what happened, what is my my behavior, my performance in patient with dyspnea or with abdominal pain or with transient loss of consciousness. You would be able to assess the performance of your emergency department, but here there is a great advantage that you can do that for each single doctor. Of course, in a very, I mean, respecting the privacy, only the doctor can see his own data, but every doctor can have a direct benchmark or how he's performing compared to the average. Is it possible? Yes, it is, only with an electronic health record. We cannot ask you, and we know that very well, to collect data on your patients as intensivists are doing. We developed an electronic case report form, and they register all those information manually. Now we also developed an electronic health record for ICU, but for many years they collected data until now. Many of them, they are 200s, are collecting data on this ECRF, on this case report form. It is unthinkable to ask you to do the same. I don't know here, but in Italy, an average emergency department admit from 60,000 to 90,000 patients per year. It's impossible to ask you to devote a quarter of an hour to collect data on this patient. So if we think this is the solution, you will never have access to this kind of research. But if you are able to plan and to organize and to develop, or even to extract data from your electronic health record, these can be possible. And this is exactly the aim of this project, the ECRIM. George was mentioning it just before. This is a Horizon Europe project. It's a quite big project. We are 11 partners in 8 countries: UK, Poland, Switzerland, France, Slovakia, Slovenia, Italy, and Greece. And George is the country coordinator for Greece. It's a very well funded, almost 9 million euros. And this is very complex schema, because most of the project are IT stuff. But the idea is to develop a system to extract, also through artificial intelligence, NLP, stay for natural language processing. And so we are developing a very complex model based on artificial intelligence, who is able to interpret your text notes and extract structured data from your notes. But we know that this has limits, this idea. So with this path, we know that we can have quite good database, but not as good as we want. So we are also going to develop a new emergency department electronic health record, which is conceived for the very beginning to be able to fulfill your needs, the needs of clinical practice, but also the needs of research. So it will be a very structured electronic health record, very easy to use. We did the same with emergency, with intensive care units, and it works fantastically. And through this, we want to try to reach what I showed you. And indeed, one of the two use cases of eCRIM is exactly to study this disposition decision. So the decision to admit or discharge patients. So we aim to collect databases on the patients at arrival, some characteristics of the emergency department and the hospital, of course, the final decision, develop a mathematical model with a quite complex systems to predict the probability of admitting or discharge the patient that can be compared with the observed situation to develop a calibration belt, blood, and other kind of indicators. I think that this is the only way to increase the scientific status of emergency department. This is not just to assess the quality of care. If you are able to collect information on your patients, reliable information, you can promote whatever research you are interested in. Without data, you cannot do anything. And the eCRIM motto is indeed, the man with the data wins. So let's become the men with the data. Thank you very much.